Good morning, good afternoon. The Coalition for Children Affected by AIDS is delighted to welcome you to this webinar today. My name is Karina Charkey and I manage the Coalition. For those of you who don't know us, the Coalition for Children Affected by AIDS is an independent group of 25 thought leaders from across the UN, NGO, donor and academic communities. We work together on advocacy and learning for global policy change to help children and adolescents impacted by HIV to survive and to thrive. You can find out more about us, access our free learning and advocacy materials, and become an advocate member of the Coalition on our website, childrenandhiv.org. We're here today to discuss our latest report, which is on financing for children and adolescents affected by HIV. I want to thank our partners who helped us create this report, which include the World Health Organization, UNAIDS, Unicef, and to John Stover and Peter Stegman at Avenir Health, who conducted the research upon which this report is based. A huge thank you also to the fantastic and dedicated working group of donors, NGOs, academics, and UN agencies who helped shape this endeavour over the last 2 years. We're really grateful to all of them. We at the Coalition are very excited about this report. It is a major contribution to the fight to end AIDS in children and adolescents. It reveals for the first time how much is being spent globally on children and adolescents affected by HIV, on what kinds of interventions and where in the world. It is a vital piece of the puzzle that enables all of us to see where the funding gaps are and to do something about them. This report comes at a critical time. The priority countries of the Global Alliance to End AIDS in Children are embarking on new action plans, and many more countries are busy preparing their applications to the Global Fund and PEPFAR funding cycle. Meanwhile, many countries are negotiating new political commitments to universal health coverage. It is vital that these countries have the resources to achieve their goals. We have a dynamic agenda of speakers for you today. John Stover of Avenir Health will walk us through the main findings of our latest report. And we are then joined by an eminent panel who help unpack them and reflect upon them. This includes Florence Annam of the Global Network of People Living with HIV and the International Community of Women Living with HIV. We also have Gretchen Bachman from the US Department of State, Marika Weinrocks from the Global Fund, Wale Ameyan from the World Health Organization, and Linda Navitaka from the Ugandan Ministry of Health. A warm welcome to all of our speakers. We're also very keen to hear from you in the audience. So please, can I ask you now to put your name, organization, and email address in the chat box. And I encourage you throughout this webinar, if you have comments and questions, please put them in the chat box and we will try to address them in the live panel discussion. If we don't get to you today, we will follow up with you afterwards, so do please include your contact details. I'd now like to hand over to analyst John Stover at Avenir Health to walk us through the main findings of this report. Over to you, John.
Thank you, Karina. Just waiting for the slides to come up. Okay, so this is a report of some findings Peter Stegman and I pulled together around trying to estimate expenditures and resource needs to support children and adolescents affected by HIV and AIDS. So just the definitions here, we're talking about children under the age of 15 and adolescents all the way up to, in some cases, the age of 24. Next slide, please. So the purpose is to understand as much as we can about current expenditures on these programs and understand where the funding is coming from and to compare it to estimates of resources needed. Next slide, please. So the first question we'll address is how much is currently spent for children and adolescents. Next slide. So the two major donors in this field, PEPFAR and Global Fund, both have public websites where you can go and view information that they have about expenditures and budgets. PEPFAR Panorama Spotlight Dashboard has lots of information about the PEPFAR program, and Global Fund, of course, has a similar type website. But neither website has all the detail needed to understand expenditures for children and adolescents. They're generally at a somewhat higher level. And we'll see a little bit more later what PEPFAR has done to try to address this issue. Next slide, please. So here's a special analysis that PEPFAR did for this activity to look at their program budgets, which are not the same as expenditures, but very closely follow expenditures for PEPFAR. And to try to disaggregate the spending that goes to programs that support children and adolescents. And here you can see their disaggregation. You can see that about a quarter of it goes for care and treatment. A large portion goes for prevention of mother-to-child transmission, also for orphan and support for orphans and vulnerable children. What you'll see if you go to the Panorama website, the PEPFAR website, they have this special analysis posted there, and it covers the population 0 to 24, and it's about 1.2 billion in total budgets for 2021. We're going to be focusing most of our remarks today on the 0 to 17 population, so that's about 818 million out of this total. And you can see down at the bottom the link where you can go to see the not only the table but also the methodology used to produce this. Next slide, please. So in order to the PEPFAR analysis gives us a good basis. Global Fund information is not disaggregated enough to allow us to pull out just the part for spending for children and adolescents. And of course, we're missing other donors as well as the national government's contribution. So one source that we looked at that does have estimates of all these different sources is something called the UNAIDS spending assessments. These are NASA's or National AIDS Spending Assessments that are conducted in a country to try to identify all the sources of funding coming into the country, who receives the funding, and how it's spent. So from these analyses, we can understand much finer grained detail about the sources of funds and what it's being spent on. NASA's have been conducted at least once in over 100 countries, but they're not conducted every year because they're intensive and expensive. They're usually done about every 5 years or so. You can access them through the UNAIDS website. The reports that we were able to access for this study, as I said, cover over 100 countries, but they're not all for the latest year. So on average, they're maybe about 5 years old. Next slide, please. So when we analyze the data in these national AIDS spending assessments, this slide gives you a look at the totals. So the total expenditure on children and adolescents that we found here, about 1.7 billion or so, and you can see the breakdown. So at the bottom, a large part for programs to prevent mother-to-child transmission, another large part for ART, a large part for orphans and vulnerable children. And then at the very top, you can see two maybe unusual categories to above site level, ASL, and PM, program management. So above site level includes all the activities that happen to implement an intervention, but do not happen at the clinic level or at the community level. So this might be something like training or logistics, procurement, research. So activities that are required to implement an intervention, but they don't happen at the clinic level or the community level. And then program management is the expenses for the National AIDS Control Council, the National AIDS Control Program, overall management, research, administration, et cetera. And we have to recognize those because they add a significant piece, perhaps as much as 20% or so, to the total cost of the program. Next slide, please. Here you can see the distribution of this spending by source. And you can see about half of it is coming from national governments. And then another large chunk is coming from PEPFAR. When we simply look at the national aid spending assessments to estimate the PEPFAR share, you can see it turns out to around 36% or so. From PEPFAR's latest assessment, which is for 2021, and categorizes things slightly differently, it's a larger number, about 41% or so. The gold slice of the pie there is Global Fund, and we've just shaded it in two ways. The light gold is the amount contributed by PEPFAR to the Global Fund, and then the darker gold is the amount contributed by all other donors. But in all cases, that whole slice of the pie is the amount programmed by the Global Fund and used to support the programs that they engage with. Next slide, please. Now this shows you the distribution of that spending by intervention. So again, this is for all the sources now, not just PEPFAR, as we saw before. So you can see about a quarter is for programs to prevent mother-to-child transmission. Almost another quarter is for pediatric treatment. A large slice for voluntary medical male circumcision, and a large slice for social protection programs. Social protection programs include support for orphans and vulnerable children, but also could include things like legal rights, birth registration, economic support, et cetera. Next slide, please. And this one shows you the distribution of spending by country. And the surprising thing, I think, about this chart is you can see that just 5 countries account for a little over half of all the expenditures. And then there's a number of other countries that have significant expenditures, so we've broken them out separately, but then you can see the rest of the countries in that large gray area. So if we really want to understand how much is being spent for children, it's really important that we have good information about these top 5 countries because it represents half of all the spending. And this is both because they have a high burden, as you can see, South Africa, Kenya, et cetera, or because their costs are high and they have extensive coverage, as in the case of Mexico. Next slide, please. This shows you the distribution by income group. So you can see that the allocation of spending by income group is slightly different, but the largest amounts are actually in the upper middle income countries. Although they don't necessarily have the highest burden, they have somewhat higher costs. And some of the high burden countries like Botswana and South Africa are in this group. Next slide, please. So that's a look at how much we're spending. Now the question is, how much do we need? So in the next slide, you can see one estimate of this. The UNAIDS 2 years ago released its new global AIDS strategy, 2021 to 2026. And this strategy established targets for 2025 and 2030 for all low and middle income countries by intervention. So it includes treatment, includes prevention of mother-to-child transmission, circumcision, condom programs, outreach, human rights, a whole long list of interventions. So it established targets for each one of these. And then part of the strategy is to estimate the resources required, which comes from estimating the number of people that need each service times the coverage target times the unit cost. So we've looked at that strategy to give us an estimate of how much funding is required to achieve these goals. In the next slide, you can see that result. This is the bar on the right, and it suggests that in low and middle income countries, we need perhaps $2.6 billion in order to achieve all of those targets. And you can see that the distribution of the funding is roughly the same, except for that additional large green area in the bar on the right, which is programs for key populations, which represents only a very tiny part of current spending on programs for children and adolescents. but as you'll show you later on, could be a significant portion of the total needs. So it's tempting to compare these two bars and say, well, the difference is the gap. We just need more funding. So let's take a closer look at that question. Next slide, please. So is there a funding gap? And if so, how large is it? Next slide. So to address this question, we've addressed it in three different parts. So the first one is for the biomedical interventions. This is treatment, PMTCT, early infant diagnosis, involuntary medical male circumcision. These programs, we have relatively good data on current spending and current coverage. So what you're seeing here is that the blue bar represents current coverage, 2021 coverage, according to the UNAIDS estimates. And the orange bar shows you the target. So for PMTCT, there's a target of 95%. Globally, for all low and middle income countries, we're about 89%. So you can see that for circumcision programs and PMTCT, we're actually fairly close to the target. For some others, such as treatment and EID, we're a little bit further away. So clearly, we need additional funds to achieve these targets. But we should also recognize, and that would be $160 million at current unit cost. But we should also recognize that funding is not the only barrier. For example, increasing treatment coverage for children requires finding HIV positive children, diagnosing them, and then getting them on treatment. And programs have sometimes struggled to find all the children that are estimated to be HIV positive. So it's not that there are children that are being denied treatment because there's not enough funding available, as much as it is we perhaps need more funding for new and innovative ways to find HIV positive children, get them diagnosed and started on treatment. Next slide, please. For key populations, we see a large gap because current coverage for programs for key populations is only around 35 to 40% globally, although much higher in some countries. But the targets, of course, should be closer to full coverage, closer to 90% coverage for all programs. So there's a big gap here, clearly. How much of this gap is for adolescents, for key populations in the age of 15 to 17, is hard to say. We don't have good data on how this disaggregates by age group. But we've made an estimate for this purpose on the basis of population distribution, 15 to 17 versus all population 15 to 49. So it gives us an estimate, and it suggests that there's a big barrier of a big gap, of as much as $400 million to achieve these goals. But again, we need to recognize that just providing more funding by itself for services is not going to achieve these targets, because there's other barriers: political will, legal barriers, and stigma discrimination. So clearly we need more effort around political will and legal barriers. We need more effort and probably more funding around programs to reduce stigma and discrimination. And only once we've addressed those adequately are we likely to see increases in access to services and utilization of services. Next slide, please. And then the third component of the gap is for some services that are hard to quantify, such as social protection and societal enablers. So social protection and services for orphans and vulnerable programs, including programs for adolescent girls and young women, as we see in the DREAMS program, that could include economic strengthening, training for care and support for caregivers, school-based sexuality education, et cetera, including food and clothing and shelter for orphans and vulnerable children. The reason it's difficult to define the need for these is because children and adolescents need different things in different settings. So in some settings, there may be a need for economic support. In other settings, more of a need for support for orphans and vulnerable children. So these programs are really guided by local communities that define the children in need of each type of service. And it's very difficult for us at a global level to know exactly how many children are in need of each type of service. So we allocate a certain portion of money to these programs, and we rely on local communities and local committees to try to identify that need and see that it's met. Social enablers are included in the UNAIDS strategy this time around. It includes programs to reduce stigma and discrimination, legal reform, and prevention of gender-based violence. Clearly, these programs are society-wide, not just focused on children and adolescents. Children and adolescents will benefit from making progress in these areas, but it's difficult to assign a proportion of the resource needs because these programs would be implemented nationally. Thank you. Next slide, please. So in conclusion, we do have information about current expenditures, how much we're spending on children for programs for children and adolescents, and it amounts to about 12% of total expenditures, whereas children and adolescents amount for about 6%, of people living with HIV. We've achieved high coverage for some key services, such as PMTCT and voluntary medical male circumcision, but are falling short of global targets in many other areas. Clearly, additional expenditures would be needed to achieve these global targets, but we also need to recognize that there are other constraints that need to be addressed, perhaps with more funding, or perhaps simply with more innovative approaches, better advocacy, to put the conditions into place to allow us to achieve these service targets. And finally, there are some interventions such as social protection and the DREAMS type programs for adolescent girls and young women, for which there is a clear need, but we don't really yet have good global estimates of the expenditures required. Thank you very much.
Thank you so much, John Stover. What an incredible achievement to have summarized such a huge amount of information. Everybody on this call, please be aware that John's slides are available on our website. A link to them is now in the chat. And of course, the full report with our full findings is also on the Coalition's website, childrenandhiv.org. We are grateful to our panel who are going to help us reflect on these new findings. And I'd like to first invite Florence Annam of the Global Network for People Living with HIV and the International Community of Women Living with HIV. Florence, the floor is yours. You have up to 5 minutes. Please go ahead.
Thank you, Corina. This report is important to all of us, whether you're part of a country coordinating mechanism, applying for or allocating funds, co-creating budgets and national plans, shaping policy, implementing programs, or conducting research. I urge you to use these findings to advocate, to inform, and to act. The report could not have come at a better time. The PEPFAR, country operational and regional operational plans are in process, and many countries are submitting applications to the Global Fund in this year. The inaugural countries leading the Global Alliance to End AIDS in Children, together with community representatives and networks, UN agencies, stakeholders, and partners, met in February this year and collectively agreed to the Dar es Salaam Declaration Statement of Action, underpinning very promising country commitments and plans to end AIDS in children by 2030. This report offers clarity for where we are not investing and where we must invest to realize our collective goal. I must admit that it's no surprise to those of us living with HIV and working on the front line that key populations, PrEP, and cash transfers to adolescent girls and young women stand out in this analysis as areas lacking in investment. We know from our people living with HIV stigma index data that adolescents, young women and moms, as well as key populations, face compounded stigma and discrimination, challenging their access to prevention and treatment interventions. Funding mechanisms must not perpetuate their exclusion, rather the reverse. They should be our funding priority. Tackling the gaps in funding for pediatric ART and early infant diagnosis is also critical. This ties in with impact and accountability. Case finding and retention was mentioned by countries in the Global Alliance as a significant challenge during the process of developing draft country action plans. When everyone is asking, where are the children? Communities and networks of women and young people living with HIV specifically are saying, resource us and help us find the women and the mothers, support adherence and motivate retention to care. How much you hear us should reflect boldly in the ongoing national planning processes in PEPFAR and Global Fund. It's not a question of which intervention and which population. It's also a matter of what kinds of approaches we invest in. So communities must definitely be in the driving seat for us to effectively serve those who are currently left behind. This is not only cost-effective for short-term delivery of services, but it also paves the way for longer-term cultural shifts that are needed to address social barriers and needed to end AIDS in children. Thank you for the report, John. And I note that you highlight how funding is not the only gap. Health system constraints, demand limitations, and difficulties identifying people living with HIV are also cited as barriers beyond funding. But isn't more funding critical to address these problems? The cost of tackling structural barriers, stigma, discrimination, violence, and criminalization cost money and should not be regarded as free. Community and civil society know advocacy is very expensive. Indeed, not recognizing these vital costs is one of the reasons these barriers persist. Money is not the only answer, but it must be part of the answer. $820 million should not be regarded as an insurmountable gap. We must not be daunted by this figure. Rather, we should be inspired by it. In the context of spending on international development more broadly, or even health, this is not a huge amount, but it could have a huge impact. It will save lives, ensure children and adolescents affected by HIV have quality of life. That is why we must do our best to sustain political will and dollar commitments needed to fill this gap. We can achieve the goal to end AIDS in children and adolescents by 2030. Thank you, and back to you, Corina.
Thank you very much, Florence. I'd now like to turn to Gretchen Bachman of the US Department of State for her remarks.
Good afternoon, good morning, good evening. I just want to thank Karina and everyone at the Coalition for inviting me to share PEPFAR's viewpoints on this new report. I want to thank John and the rest of the folks at Avenir for doing the report, and just to say that my comments about it are really reflective of a group of us at the State Department Office of the Global AIDS Coordinator. They include my colleagues in pediatrics, in PMTCT, in gender, and in prevention. All of us who work on issues around children and adolescents, and also some of our folks that worked hard on contributing to the report from our program efficiency team. And just to say that they all join me in offering appreciation for the Coalition's efforts to estimate the shortfalls in the HIV/AIDS response for children and adolescents. And I would say that we at PEPFAR share your concerns about the considerable gaps that remain for children and adolescents in terms of the 395s. In fact, our Ambassador Nkengasong, launched on World AIDS Day this past December a new framework and strategy for PEPFAR. It's our new 5-year strategy, and you can find it on the State Department website. And the strategy has 5 key strategic pillars and 3 enablers. And the first strategic pillar, which you can see over my shoulder, is health equity for priority populations. And certainly one of those 3 priority populations that are called out are children and adolescents. The other 2 are adolescent girls and young women, and key populations. But all to say that, you know, when you hear the ambassador talk about our strategy moving forward, it's there's nothing more important than closing the gaps and having equitable access for all of these groups. And again, children being really very much part of this. So the question that the coalition raised, in terms of funding and resources needed to close the gaps for children is obviously very timely. And I think the Avenir report is an important first step in trying to answer what's a very complicated question. I think that the fact that their attempt to capture spending for children across really multiple donors, different subpopulations, different ages, very diverse intervention areas was certainly a very ambitious task, which clearly they were up to. So I think it was a really good first step. I think we can all acknowledge that there are limitations to the data that's out there to help us answer this question at this point. For example, some of the data, a lot of the data I think was pulled from national AIDS spending assessments. And like any self-reported data, there are issues in terms of consistency, how often countries report. Some of the data is more dated than others. For example, it could be a couple of years old, and some people report on certain aspects and not others. So just to say, there are limitations. I think the other issue that we run up in trying to answer such an ambitious question is just the diversity of what we're looking at. I think it's fair to say that each of the subpopulations named in the report, adolescents at risk, children living with HIV, children who are part of key populations, and I realize those aren't always distinct, they are definitely overlapping, but they all really deserve a thorough examination on their own of what is needed. So in any case, regardless of the limitations faced in trying to put this together, I think what Avenir has put together for global stakeholders to try and answer this question is really a good start. I think that the more we drill down, we're going to find that funding needs vary across countries, and that our recommendations and maybe what we look at needs to be very country specific and specific to some of the unique context gaps in each setting. And I would just say that as a donor, we're very open to ensuring transparent reporting that helps people to understand where PEPFAR resources are going and being spent on children and adolescents. We are lucky to have an unusually robust reporting framework and system. And so in response to the coalition's request, we were able to put together an estimation of our children's funding. And we calculated that in fiscal year 2021, in terms of budget, we had budgeted over $1.2 billion US collectively for children, adolescents, and youth. And that would be exclusive of management and operational costs. Again, lots of caveats in those, in terms of who do you count, which line items do you count within that, but it's a start, and that's what's most important. And certainly one we'd encourage that all donors join us in helping to do over the next couple of years as we try and close these gaps for children. So thanks again for having me, and I will turn it over to the next speaker. Thanks.
Thank you very much, Gretchen Bachmann. We're honored to have Marijke Weinrocks from the Global Fund here with us today. Marijke, can I invite you to make your remarks?
Thank you so much, Corina, and thank you very much for having us and for presenting this really important research on the funding gaps to address HIV in children. And it's a great follow-up conversation from the one we started in Montreal. And I acknowledge the limitation to some of the data that were just mentioned, but it's very clear that we do have a significant funding gap to reach our collective goals of preventing new infections and diagnosing and treating children and adolescents with HIV. But as John also said, the lack of funding is only part of the problem, and we do need to address issues such as lack of political will and tackling stigma and discrimination. The Global Fund's newest strategy highlights the needs of children and adolescents across HIV prevention, diagnosis, treatment, and care, as well as the need to differentiate and tailor program responses and to reduce barriers and inequities across populations. Key components are early HIV diagnosis and rapid access to treatment for children and adolescents, a focus on HIV prevention among children and adolescents, and the prevention of vertical transmission of HIV to children. The Global Fund investments in HIV programming in our current cycle 2020-2022 are close to $6 billion. And this does include diagnosis and treatment of children. However, as John also mentioned, the breakdown between pediatric and adult investments is not always well captured or reflected. And while we've made extensive efforts in the last couple of years to address HIV incidents among adolescent girls and young women in 13 high-burden countries in East and Southern Africa, we are also committed to closing the equity gap for children to achieve impact and parity with progress for adults, as highlighted in our guidance for the next grant cycle. We need to do more as well with adolescent key populations, which we also heard from John, and this will require greater prioritization of children in response. We strongly support countries to do this. We have adapted the tools we will use to monitor programmatic and financial performance in the next cycle, which hopefully will go some way to addressing the current gaps that also came out of John's presentation, so that going forward, they should better reflect the ambitions and focus of the new strategy. And these revisions also allow us to better track investments and expenditures on children and adolescents. In our modular framework, which is the guidance document for budgeting, we now have separate budgets for pediatric treatment and care and for elimination of vertical transmission of HIV, syphilis, and hepatitis B. This should make it possible to better track investment for children. But the key question is, of course, how to ensure that resources will be allocated and prioritized to ensure children are not left behind in the discussions at country level. We will need the full partnership to make this happen, and I'm looking at everyone in this webinar. Guidance for the next cycle emphasizes children and adolescents and allows budgeting specifically for children with HIV. However, countries need to prioritize this in a very constrained fiscal environment. In addition, domestic contributions for children and adolescents are not easy to track and follow, and children and adolescent HIV services are hard to distinguish from adult services. So we will not be able to track all spending for these populations. The international tools we have at our disposal just do not make this possible. The Global Fund programs are country-led, and at this critical time of funding request development, we request that as a partnership, we work with the CCM and all the in-country entities to ensure that the needs of children and adolescents are addressed and prioritized in concept notes and funding requests, and that data on gaps in the care cascade for children and adolescents is available to inform these discussions, and that partners support messaging and advocacy and work with civil society and community organizations to champion children's needs and rights and make sure their voices are heard. We're looking forward to continue working with all the partners, including the Global Alliance to End AIDS in Children by 2030, to bring children and adolescents to the forefront as we enter our next funding cycle. Thank you very much, and back to you, Corina.
Thank you very much, Marijke, and it's so exciting to hear about all these new initiatives within the Global Fund and the stage set for real change in the next funding cycle. It's a pleasure to hear about this detail. I'd now like to hand over to Wole Amayan at the World Health Organization. Wole, the floor is yours.
Thank you very much, Corina. And let me start by congratulating Sikaba, and of course, John, for what I consider to be a groundbreaking work and very insightful work as well. I have read through the report, and I can, see very clearly how timely this report is. We're 7 years to 2030, the end of the SDGs, and without any doubt, this is the time for us to get off our seats, buckle our shoes, and begin to have the sort of honest and critical discussions that are needed to get us to where we need to be. So we have labeled this work a report, but permit me to use sort of a different term. I would call it an expose. An expose because all of a sudden we begin to see why, and again, acknowledging that, you know, funding is not all the problem, but of course it's one of the significant problems. We begin to see why we have some of the different gaps, the sources of gaps and the different distributions. We begin to tie some of the puzzles together. We see why, you know, with adolescents and children, we see some of the shocking, you know, quite shocking statistics that we see all over the globe. We can begin to understand as well why, in part, only half, you know, 50% of children are on ART despite available drugs. Again, we're going to say there are problems with health systems, and that is true, but we do have, looking at this report, significant funding gaps that we all have to come together to see how to fill. Of course, we can begin to see, when we look at the PrEP data that John presented, we can begin to decipher as well why, globally, we have 3 in 4 new infections amongst adolescent girls, and in some regions, 6 in 7 of new infections amongst young people are amongst girls. So without a shadow of doubt, I think this report, this expose, begins to show us why, even if it's not all of the reasons, at least we can begin to see and connect to why we have some of the gaps that we have. Now, beyond those gaps, this report as well allows us to begin to ask some critical questions. Now, childhood and adolescence represents one of the most vulnerable, defenseless, unprotected periods of one's life. I mean, there's no question about that. Now, the question we should be asking now is, if governments and funders and donors are not adequately funding this period of life, then what are we funding? How are we funding? And, you know, are we funding the most vocal, or are we funding the most vulnerable? Are we focusing on the most expedient or on the evident? And I think this is where all of us as a collective, we have to be, come off with humility and begin to ask, very serious, critical questions that will enable us begin to put things in perspective and put the money where it is supposed to be. I think what is great as well is that we can begin to move as well into starting to redress some of this. And I think, Florence and some of my colleagues here have begun to mention, of course, the Global Alliance. We have one clear opportunity, I think, with the new Global Alliance to end AIDS in children by 2030. For the first time in a very long while, we have country ministries of health, communities of people living with HIV, coming together in a process that has been as thorough as it has been very rigorous, highlighting not 20, not 30, not even 10, but 5 core priorities in 4 pillars to end AIDS in children in 12 countries by 2030. These priorities have been backed most emphatically by ministers of health and by the top political echelons in those 12 countries. Now, we continue to mention political will as one of the problems, but I'm not sure we can really, in good conscience, speak about political will as a serious gap, because from the processes that we've gone through in the last few weeks, few months, we've seen, quite high-level political commitment, coming to the table, and we have to use this as a latchboard to begin to harness funds and direct funds to where it should be, as defined by countries and by communities themselves. So what does this expose mean for us, and what can we do? First, we need to desist from moving towards what becomes the most vocal towards the most vulnerable, and from the most expedient into what is the most evident. With the Global Alliance commitments, funders, governments, UN partners, we have a responsibility to listen. The Alliance commitments presents a humbling moment for all of us. We have to listen to those who bear the burden and who understand their needs. In essence, we have to listen to communities. Second, we need clarity on funding. And I say this, with all due respect. There has to be clarity on how much is being committed, who is deciding the priorities, whose priorities are these? We need to make a direct call to urgently use the ongoing and upcoming Global Fund and CUP processes to prioritize children and adolescents in line with clear national targets and national priorities. I think that has to be, the bottom line. Third, we need a global and unified call to action. And I'm glad, I have, colleagues here who are speaking on the same page, to be led by communities, demanding that funding needs to be matched to needs needs to be matched to voices. And the voices that most matter are the voices of evidence and the voices of communities. I think it's gratifying to note from the report that half of spending is from national governments. With the Global Alliance, I can confirm, like I said earlier, that we have really strong political will and commitment, which brings me to my third point. It is one thing to have the political will and the political commitment, but it is a completely different ballgame. It's a different skill to translate that will, that political will, that political commitment, and leveraging that into action. And that is where I am calling on colleagues from SICABA and all others to see how we can generate that skill to make this translation happen. Finally, it boils down to communities, no questions. We've been quite good at rallying with communities and standing with communities, but I think we're doing it wrong. It is now time not to rally with or in front of communities. We need to rally behind communities, and we need to make sure that we fund what matches with evidence and what matters to communities. The Global Alliance to End AIDS, of course, presents us a rare opportunity to rally behind communities and to fund what matters and to make funding matter. So I'd like to just thank you all again. And WHO, of course, will continue to strengthen our partnerships to make sure that we continue to move forward in the right direction that we need to move. Over to you, Karina.
Thank you very much, Wole. Very important words and some great suggestions for what we can all do next to build on and support and achieve the goals of the Global Alliance. I'd like to hand over to Linda Nabitaka from the Ugandan Ministry of Health. I'm afraid we're running slightly short on time, Linda, so if I could ask you to keep closely to time, and apologies for rushing you. Over to you, Linda.
Thank you. I am unable to turn on my video. Okay, thank you. It's now on. I want to first of all thank the coalition and the organizers of this webinar for bringing us together and for asking me to speak on behalf of the 12 priority countries for Global Alliance. And I want to thank John Stover and his team for a research that is well done and comes at a critical time when we are trying to head towards epidemic control, but also recognizant that resources towards HIV are dwindling, especially in the midst of other critical epidemics like COVID and Ebola. And at a time when we are reawakening the call to end pediatric AIDS in the Global Alliance. I think it's indeed very difficult to know how much is spent on children and adolescents, especially because they get lumped up into the bigger program costs, including ART and PMTCT. But as one of the previous speakers said, it is also gratifying to recognize that African governments are contributing to the response of children and adolescents from domestic funds alongside the donor support, giving almost near to 50%. But however, it's also important to recognize that more could be done if better prioritization and planning were to be done by the governments. Then we would be able to cover even more. We also recognize that the Global Alliance gave us an audience to rejuvenate the political involvement in the global in ending AIDS by bringing together the community, the programmers, and the government heads to plan to plan for the Global Alliance initiatives and develop the work plans together and reaffirm commitments from the governments. And we shall need all the different stakeholders, including our community and the donors, to continue ensuring accountability of our governments as we continue to program. There are without doubts gaps in funding for children and adolescents in all the 12 priority countries, including and especially Uganda. And we've articulated these very well in our work plans. Our gaps have been that need to be addressed in the work plans include the early identification of positive children, which requires good programming for early infant diagnosis, as well as prevention of mother-to-child transmission. And we know that most of the children, most of the reasons we are not identifying children early is because we end up losing the mothers from the prevention of mother-child transmission cascade. And most of the issues affecting that loss of mothers, issues of culture, issues of stigma, as everyone has said, and these are issues that are very difficult to program for, but need a lot of resources for us to be able to navigate them. Also, identifying children and adolescents that were missed by the prevention of mother-child transmission cascade is very key. It is one of the major areas that we need to put a lot of emphasis on, and we need to be able to invest resources in the HIV testing modalities, including the use of self-test kits for triage, family-centered HIV testing, and communications campaigns, including the Know Your Child status. This calls for investment in diagnostics and supplies, and also educating everyone on how to use them well, and motivating everyone to participate in this. I want to thank all the donors on this call, including the Global Fund and PEPFAR, and thank them for their continued commitment to support the response in the low resource settings, but also urge them that in the upcoming Global Fund proposals and the PEPFAR COP that is ongoing, we should clearly look and see that the gaps in children and adolescent programming are well addressed beyond PMTCT and EAD to cover issues like multi-sectoral programming, including involving education sector, as well as other barriers, social barriers to service delivery. Once again, I want to thank everyone and to thank the coalition for having brought us together, and thank again the research that is coming at a very critical time. Over to you back, Corina.
Thank you very much, Linda. It's great to hear from one of the priority countries of the Global Alliance. I would like to thank our esteemed panel. I've been very honored to share this platform with you. And I'm now going to hand you over to Luann Hatane, who's the Executive Director of PATA and also the co-chair of the Coalition for Children Affected by AIDS. Luann will give her remarks on behalf of all coalition members and officially close out this meeting. So over to you, Luann.
Thanks, Karina. I'm just going to wait. Yeah, great. I can see the slides are up. So thank you, Karina, and thanks to all participants for joining. The Coalition for Children Affected by AIDS is motivated by this research and its potential to contribute in our collective efforts to ending AIDS in children. A huge thanks to Avenir and all our partners and members already thanked who have contributed in shaping the report. I'd like to share some reflections from the members of the coalition on the new research findings. These are available in the report and are based on the experience and evidence shared by members on what is needed and what works. Next slide, please. The overarching message is we can't and must not wait. Progress is possible even when funding is scarce. There are things we can all do today, in the coming months, years, to improve financing for children and adolescents. Next slide, please. For this, though, we urgently need governments and donor leadership to prioritize children and adolescents affected by HIV, especially those affected by poverty, social and structural exclusion. This includes the children of key populations, adolescent parents and their children, orphans and vulnerable children. These are the populations we can see being left behind. Reaching these populations and focusing on service delivery and those who deliver services on the front line will enable us to better achieve our global targets, sustainable development goals, and will provide us important pathways to universal healthcare. We've already heard about mechanisms like the New Global Alliance, the Global Funds Budget Optimization Process, the upcoming PEPFAR COP. These are all opportunities to call for increased investments and ring-fence funds in our donor and international and national budgets. We also remain painfully aware of the inequalities that drive HIV. And in a continent like ours in Africa, we not only suffer disproportionately from AIDS, but still remain hugely dependent on international funding, with many countries on our continent in or at risk of debt distress, resulting often in difficult and impossible trade-offs, often at the expense of our children. So this is most certainly not the time to be making budget cuts, but rather to reflect on and improve upon conventional funding mechanisms so that we can actively work towards decolonizing systems and practices that constrain local country ownership and community-led solutions. Next slide, please. When we know what works in our programming, we should focus more on closing those funding gaps so that these can be scaled. Already mentioned, early infant diagnosis, self-testing, family-based testing, maternal retesting, art for older children, prevention for adolescent girls and boys, pediatric DTG, advanced HIV disease management for children, long-acting PrEP among pregnant HIV-negative women, longitudinal tracking of mother-baby pairs, and early linkage to treatment and prevention services. We also need to think about ways we can build stronger and more integrated systems for health so that our funds can be leveraged and shared better across different programs. This can help utilize resources more responsibly, effectively, creating opportunities to align our programs. And we have good examples in terms of pandemic preparedness, universal health coverage, education, economic growth, and many other social services that directly affect children and adolescents. Investing in intersectoral and clinic community collaboration is vital. This builds mechanisms to promote and sustain coordination locally and align strategies to particularly target excluded children, adolescents, and caregivers in a joined-up package of support, social protection, mental health, support for gender equality, protection from violence, early childhood development, and also offering employment opportunities. Next slide, please. So let's work together in increasing visibility on funding for children and adolescents affected by HIV and the impact this is having. This is going to be needed for sustaining commitment and maintaining accountability. Let's think about developing or supporting a simple but unified framework that we could apply across countries, across donors, that could track where funds are being spent on children. Having more disaggregated detail could also help us better link our results to these investments and help us identify better who is not being reached. Let's also strengthen the voices of children, adolescents, caregivers, and those who deliver services on the front line in monitoring and decision-making processes. We've already heard about different country coordinating mechanisms, the PEPFAR COP process, and the new Global Alliance, where we also want to make sure young people are engaged fully in national thematic and technical working groups. However, and I think really importantly, this must come with real commitment to building capacity to engage with confidence and fully represent constituencies. And let's make sure that community-led monitoring systems include the voice and experience of both service users and those who deliver the service. Let's continue to invest in research and know what's happening to children and adolescents and act thereon. Data on this population must be better incorporated into our data collection, but must also be made accessible and more understandable so that it can inform our decision-making at all levels. And greater attention and investment must also be given to operational research so that this can better unlock barriers in implementation, document mechanisms that can better enhance service delivery to those who need it most and in places where needed most. Next slide, and then the next slide. So just what's next for the coalition? We're really just inviting all of you to join the coalition on a much longer journey to improve financing for children and adolescents affected by HIV. Over time, we want to build a fuller picture, analyzing, for example, financing from private trusts, foundations, domestic sources, and taking a deeper dive into particular countries. We really invite collaboration in this next phase of our research. Perhaps you're from a private trust or foundation and want to unpack private philanthropy a little more. Or you're a priority country within the Global Alliance and you want to unpack national financing in more detail. Or you're interested in better understanding how to improve our financing for holistic service delivery. Please reach out to us. On the last slide, again, you can see the contact details for the coalition. And I think just in closing, just a reminder, let's not wait. Progress is possible even when funding is scarce, especially when working together, improving financing, service delivery, and ensuring all children can start and stay AIDS-free. So just lastly, on behalf of the coalition, a huge thank you to everyone for your participation, and particularly to all our esteemed panelists for providing time on today's webinar. So big thank you to everyone, and now formally close the meeting. Thank you so much.